We're very happy to have you here and to learn from you. So the stage is all yours.
Thank you very much for your invitation. I'm very happy to be with you. So I will start. Sorry. Sorry. So what's new in cross-linking protocols? So we know all that cross-linking is a procedure whereby riboflavin sensitivation with UVA radiation induces stromal crosslinks. So this is all this, we know it. This increase corneal biomechanics, and it halts the progression of keratoconus, of pellucid margin degeneration, and it's also a treatment for post-laser vision correction ectasia. It can be also used in non-ectatic diseases like bullous keratopathy and in corneal infections. So let's see the indications of cross-linking keratoconus. So in the beginning, it should be a real keratoconus. Not any asymmetry, not any irregularity in the cornea is keratoconus. So I see a lot of cases every day that cross-linking has been done or has been proposed, and it is not keratoconus. Is it other things? It's a scar in the cornea or other thing. So we should be be sure that it is keratoconus, because we are treating the stroma and treating the collagen. So I will discuss the keratoconus with all topographic and tomographic criteria. So we are diagnosing a real keratoconus with abnormalities in the anterior surface as asymmetry and the SRAX, skew radial axis, plus abnormalities in the posterior surface by abnormal elevations that what we can have in all devices now, elevation devices, or bulging in the posterior axial maps as we have in the MS39. And we can add, if we can have the epithelial mapping, the donut image that certify the keratoconus. So if we have these three parameters, we can see this is a keratoconus, and now we can see if we will cross-link. So this is the parameters for diagnosing a keratoconus. This is an image from MS39. Next thing, the keratoconus should be progressive. Cross-linking is not a treatment of keratoconus, but is a treatment to halt the progression of the disease. If the disease is stable, we should not cross-link. So there are a lot of criteria. There is not a consensus now. We can say 2 diopters per day. There are in other in other papers you can find 1 diopter, even if 1 diopter sometimes is just noise of the machine, and a thinning of 15 microns in the same area. So you should have the 2 diopters, the increase of Kmax plus the thinning, because sometimes if you have the increase of Kmax, but we have thickening of the cornea, it is only a thickening of epithelium, and it is not a progression. So we have, you can have these devices like this. We have the old image, the new image, and the differential. You can have it in all the devices, Pentacam, Galilei, and all. This is an image from MS39. So we should be sure that it is a real keratoconus and it is progressing. But there are some other cases like pediatric keratoconus. Pediatric keratoconus is an indication because in children and young adults, the keratoconus is very, very aggressive, and we do not need to monitor. You have here a case of 7-year-old boy with bilateral keratoconus, and he got his cross-linking the same day. You have also some other cases that are indication like PMD, pellucid margin degeneration, because it's like keratoconus, but it starts at 30 years old, and it can progress until 40 and 50 years old. So when you have a pellucid marginal degeneration, not pellucid-like, you should have the thinning in the periphery to diagnose it. And you have iatrogenic ectasia like post-LASIK or post-SMILE ectasia, because the apparition of the ectasia is a progression itself. What is our contraindication of cross-linking? So we have pregnancy, active unstable immune disease, active herpetic infection, when you have a big central scar that will lead to keratoplasty, so no need to do cross-linking because you will go to keratoplasty, but VOCT striae are excluded, and you can do cross-linking with VOCT striae because you can follow with a conservative treatment like contactology or conservative surgery. Stable patient with keratoconus and when he is more than 50 years old is not an indication, because after 25 the keratoconus is not so aggressive, and if you can follow the patients every 6 months and you see that all the parameters are stable, then so you should not cross-link. And do not cross-link when the patient have an acute allergy. Sometimes patients are very hard allergy, and if we do the cross-linking the same day, you will give a big inflammation and a lot of problems. We have to treat inflammation before to do the cross-linking. And we cannot do cross-linking to non-realistic patients. Some patients think that cross-linking is a procedure like LASIK or like any refractive surgery. They don't know that they have a problem, they have a disease, so they have to understand that this is a treatment only to halt the progression of the treatment and not to have a 6/6 vision. What are old limits of cross-linking? The first old limit was that the cross-linking was allowed only when stroma was more than 400 microns. I mean epi-off. When you remove the stroma and you measure remove the epithelium and you measure the stroma before, when the thickness was less than 400 microns, we told to the patient we cannot do the cross-linking to fear of endothelial loss. Some solutions were proposed to sort out to this issue. So the proposals proposed was to make a difference, to change the cornea, hypotonic riboflavin by Farhad Hafizi to make cornea swelling, but it gives some corneal edema. There are the technique developed by Susan Jacobs from India, the contact lens assisted cross-linking, but there is a problem of oxygenation of the cornea, and there is the epi-on technique and iontophoresis. The second limit of cross-linking, it was compulsory done in operating theater. It means that it was considered like a surgery, and all patients should be referred to centers and hospitals. And this is problem of cost and of transportation. And we know there are a lot of places in the world that cannot afford this possibility to go to a big hospital. And we know the frequency of this malady, of this illness. So what is really new for the problem number one? I mean, thin corneas. The 400 microns is no more now the limit to cross-link a cornea. We cannot tell to a patient that have less than 400 microns stroma, we cannot cross-link you. And this is the result of a hard work of two scientific teams. The Italian teams, Cosimo Mazzotta and his team, who studies demarcation lines of every protocol used by a Vedro machine, and they use it for every 20 cross-linked eyes, and they made what they called M protocol, based on demarcation lines suitable for every CXL, and this is suitable for every CXL device. These protocols use the fluence of 5.4 joules in all cases, but changes the energy, the time, and the mode, pulsed or continuous, like this. So this is the paper from Cosimo Mazzotta, and I will explain more. So if we see this draw, you can have the demarcation lines of each protocol. This is the 3 milliwatt protocols, I mean the Dresden one, 9 milliwatt protocol, accelerated, then accelerated but 15 and pulse. And when we accelerate, when we make the energy higher, the demarcation line will be smaller. And he calculates for every protocol roughly an average of demarcation lines. So if in every case you measure your stroma, and you take the 2/3 of the stroma to be dedicated to the demarcation line. For instance, you take I think 350. So 350, you will take the 2/3, and you will choose here, for instance, this protocol 30 milliwatt continuous. So you will adapt your protocol on the stromal thickness, but you take off the safety part of the stroma, 100 on 150, to avoid endothelial cell loss. This is the M protocol. This is a second new solution for the problem, and this is due to the works of Farhad Hafizi from Switzerland, who developed the sub-100 protocol. This protocol can be used from 400 to 200 microns, and a case of keratoglobus has also been treated without endothelial loss. So the sub-100 protocol uses the same isotonic riboflavin formulation. The energy is the same, is 3 milliwatt centimeter square, like Dresden protocol, but you change the exposure time that will reduce the fluence, like following this table. This is the article, this is the technical settings, and this is the sub-100 protocol. So when you go to your OT or your room where we do your cross-linking, so you see the stroma, you measure the stroma, and if you have 200 stroma, you put 3 milliwatt, and you put the light for only 2 minutes 30, and you will have a demarcation line of 150. So you can go until 200 microns, and that will have only 1 minute. So now we cannot tell to a patient under 400 microns that we cannot cross-link you, but we can go until 200 epi off, I mean without epithelium. What is the solution for the problem number 2, which is operating room? We know that keratoconus is not a rare disease. I see every day 10, 15 cases per day. So it is not rare, and it makes, I know in all of the world, there are some problems of transportation for costs. So Farhad Hafizi has developed with his team a device which is adaptable to slit lamps, and you will not need a space, a clinic to do this, and you can just adjust the device on your slit lamp, and you can do the cross-linking with like this picture with the courtesy of Farhad Hafizi, and we can resolve the problem of cross-linking and keratoconus in a lot of places in the world. So, what's new about AP-on cross-linking? AP-on cross-linking was controversial in the last decade. This technology is gaining benefits with the anthophoresis, oxygen supplementation, boost AP-on developed by Avidro. Demarcation lines and stabilizations are promising. Long-term studies should be performed to verify the efficiency as it's safe procedure. So for me, I use it when I have a non-aggressive keratoconus, patient more than 25 years old, and where I'm afraid of complications. Sometimes we have some complications, some scars, some necrosis. I have had a case of necrosis after AP off. So when the patient would not sign the paper that gives me the authorization to do the cross-linking AP off, so I tell him it's better to do the AP on than to do nothing, because the AP on gives some results, and there are now some papers to attest this. But I think we need more time to verify all this, and also with the patient with family that refuse complication rate of AP off, and sometimes we have some patients with a very good visual acuity, 9 out of 10 or 7 out of 10, and we are afraid to have a decrease of their vision. So the efficiency of cross-linking, I think thousands of articles in all of the world are certifying the efficiency of cross-linking to hard the keratoconus. The success rate is more than 95. There are some failures, but when you have a failure case, you have to check the behavior of the patients. If it is an eye rubber, and eye rubbing is not only rub, it's rub, is push, is the way who is sleeping. If he's sleeping up, face down. And then you have to check if there is any thyroid hormone, the hormone levels, if there's hypothyroidism. So this is a differential topography that shows the huge difference. This is before, this is after the cross-linking, and we have a flattening, or a very good flattening in the area of the keratoconus. So as a conclusion, keratoconus is not a rare disease, and the only way to have the progression is of all cornea ectatic diseases is cross-linking, not contact lenses. That's like, I don't know what in the culture of some doctors, they say the contact lens stop the keratoconus, but it's not true, because the contact lens will not touch the cornea. This technique is more and more safe. It's customized to every patient, available, affordable for all of patients. The best way to avoid blindness from this disease is to check the maximum of children. We see now a lot of kids with advanced keratoconus at 11, 9. I cross-link every week a kid between 9 to 13, as possible by corneal topography, and more if they present any of family history of keratoconus. Avoiding rubbing eyes is a key to how the progression in combination with cross-linking. Cross-linking is a procedure that can be preceded or simultaneously done or followed by all the other procedures. We can do PRK before, we can do PKA in the same day, we can do it after, We can do phakic IOL, we can do phaco surgery after, and we can also do intracochlear insertions before the same days or after. So it is very, this treatment can be done before, after all these procedures. Thank you very much for your attention. And if you have any question, I'm here.
Thank you so much, Dr. Yasser. What an informative talk, and it is always very important to be up to date about what's new in cross-linking protocols. So Irina and Yelin, what are your thoughts